Good afternoon, everyone. Welcome to the second webinar of our Women's Health in Focus series, which is hosted by the Office of Lifelong Learning Physician Learning Program here at the University of Alberta. My name is Denise Campbell-Sher. I'm the Associate Dean in the office. Our office is committed to providing reliable updates and resources for clinicians, healthcare professionals, and everyone committed to providing best clinical care for patients. The University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Niihau, Niitsitapi, Métis, Nakota, Dene, Haudenosaunee, and Anishinaabe lands that are now known as parts of Treaties 6, 7, and 8 and the homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. I'd like to start with a little bit of housekeeping information. Please use the chat feature if you have questions about technical difficulties or L3PLP programs and services. If you have a question for the speaker, please use the Q&A feature of the webinar. Please review what's already been asked and upvote those questions you'd like to see answered. We cannot guarantee that the panelists will be able to respond to all of your questions. A recording of the webinar will be sent to all participants who registered. Participants can claim CME credits and complete a personal development activity using the My Lifelong Learning Plan tool. For more information, please see this QR code on your screen or our Office of Lifelong Learning website. This activity has not been formally reviewed by the CFPC or Royal College. However, it is eligible for non-certified credits. Additionally, Main Pro Plus participants may also earn additional certified credits by completing a linking learning exercise. And the My Lifelong Learning Plan also gives you certified credits. Today, we're very pleased to welcome Dr. Nick Poirier, the physician lead for the Women's Health in Focus webinar series, and Dr. Danika Hawthorne, our speaker today, who will provide an overview on postmenopausal bleeding. Dr. Danika Hawthorne is an obstetrician gynecologist who practices here in Edmonton at the Grey Nuns Community Hospital. She attended the Northern Ontario School of Medicine in Sudbury and then moved to Edmonton to complete her residency in obstetrics and gynecology at the University of Alberta. She works as a generalist with special interest in menopausal care and is the gynecology lead at the Covenant Community Health Lakewood Center Menopause Clinic. So thank you everyone so much for coming. Welcome to the webinar, and I'm going to hand it over to you, Danika.
Perfect. Thank you so much. And thanks again for having me. It's a pleasure to speak to everyone today. So I'm just going to get my slides up here. And then if someone can just confirm that we can still see them, that would be fantastic.
Looks great.
Perfect. Okay. And so today we're going to talk about postmenopausal bleeding and essentially an approach for primary care providers. This is a huge part of every gynecology practice in our city for sure, and I'm sure it's growing across the country. And so today's goal, the overarching goal is just to give you some tools so that you're able to appropriately manage and refer these patients when necessary. So my financial disclosures, I have been a paid speaker in the past for both Bayer and Astellas, but neither of those things are applicable to what we'll be chatting about today. And so throughout this presentation, I'm going to be using gender terms, including female, women, she, her pronouns to refer to people born with gynecologic organs. Given the diverse patient population that we all serve, please consider doing a reproductive organ inventory for your patients, for all patients who identify as cis female, trans female, gender diverse, and intersex. So, just a brief rundown today on what we're going to be going over. So, first, we'll be going through the menopausal transition and expecting bleeding patterns. If you attended last week's session with Dr. Seal Grant, I'm sure she went over this in details with you. But specifically, we're going to be looking at expected bleeding in these patients. We're going to be focusing mainly on the provincial postmenopausal bleeding clinical pathway that the most up-to-date version was published about 1 year ago. Some more specific patient populations that we'll be touching on are postmenopausal bleeding in patients on menopausal hormone therapy, as well as patients with asymptomatic thickened endometrium. I've got some resources for you, and then hopefully we'll have lots of time for questions. So the menopausal transition. Now, these slides are going to contain a lot of information, and so I apologize for that, but I'm going to highlight exactly kind of where we want to focus on for the sake of this presentation. So to kind of orient you to what this is the straw plus 10. This is how we classify reproductive life stage, especially when it comes to the world of menopausal and perimenopausal care. FMP refers to the final menstrual period. And so, what we'll be chatting about is mostly after that final menstrual period or postmenopause. But in the menopausal transition, both early and late, we can see changes to normal bleeding patterns. And what is normal is a wide range, which I completely understand can be anxiety producing. But just know that what's normal for one patient might not be normal for another, as there is a large realm of normal. In the early menopausal transition, these are your patients that are starting to have like up to a 7 day difference in the length of consecutive cycles. They're still cycling roughly every month, but there is some variation within that. In the late menopause transition or late perimenopause, that interval of amenorrhea or not having a cycle is now greater or equal to 60 days. And so these are your patients that will go several months in between cycles, and most likely when that cycle does come back, it's probably going to be heavier than it has been previously, and we'll touch on why on our next slide. Again, lots of information, but I'm going to go through this with you. And so this is actually a graphic that I draw out for my menopause patients, and especially my perimenopause patients quite frequently. And so what this is showing us is a concept called luteal out of phase ovulation or a loop cycle. And so what this is showing us is so at the left side of the graph, we kind of have like a day one of a cycle with normal menses. Now, when we get into perimenopause, the brain is like sending down the signals to ovulate every month, like we have our entire lives. But you know, the ovaries just don't have as much in the tank as they used to. And so we get recruitment from the ovaries in varying time frames. So the number one and the number two is showing where actually two dominant follicles have been allowed to develop completely and are released. And so then we have these two peaks where our estrogen is higher. And so then the subsequent menses later on the right side of the slide is very heavy because we've had a whole lot of estrogen because we've had two ovulations. And so those can be our really heavy cycles. So postmenopausal bleeding. As you probably touched on last week, we know that menopause is a clinical diagnosis that's made retrospectively after 1 year of amenorrhea. The average age of menopause in Canada and the US is about 51, 52 years of age, but we've got a wide range of normal, anywhere between 40 to 58. With advances in modern medicine, women now spend approximately 40% of their lives after menopause. Our most common ideologies for postmenopausal bleeding are benign. However, it is critical that malignant causes be identified in a timely manner. And so, what we're going to do from this point forward is really try to suss out where we are concerned for malignancy. We always think about the gynecologic causes, or sorry, I may be speaking my bias as a gynecologist, but my referral pathway we tend to think of the gyne causes for postmenopausal bleeding. Polyps are the most common, and the vast majority are benign. Then we get into like hypotrophy or atrophy being the next most common. Then we can get into our proliferative or secretory, our carcinomas. Fibroids will sometimes bleed after menopause, although again, this is uncommon. And then lower down is actually our hyperplasias without atypia and then with atypia. Or other ideologies. So, if your patient still has an intrauterine contraceptive device in situ, they can have irregular bleeding similar to patients prior to perimenopause or menopause. Menopause hormone therapy can certainly cause bleeding, and we'll touch on when we're worried and when we're not worried about that. Anticoagulated patients tend to be a big headache for both the gynecologists and the hematologists when their uteruses don't really cooperate with the anticoagulation. Tamoxifen specifically, I've got this one asterisked because these patients were worried. We always want to have an endometrial biopsy and or see a gynecologist specifically on these patients. Now, the like non-gynae kind of organ system, so inflammatory bowel disease, certainly it can be difficult to know if the bleeding is coming from the vagina or the bowel, so that goes along with hemorrhoids as well. Urethral disease can also cause bleeding as well as bladder disease. Now this is my one graphic gynae photo, and I tried to minimize the graphic gynae photos, but I just wanted to highlight what urethral carbuncle looks like. It's very common that I see this in my practice. This is a benign finding that can sometimes cause bleeding, sometimes cause irritation, and is not something that we're concerned about. And if the patient is symptomatic, can easily be treated with vaginal estrogen. And I'm sure that Dr. Vassas will go into great details about that at next week's session. Okay, so now let's go through the provincial postmenopausal bleeding primary care clinical pathway. This is going to be small, but don't worry, we're going to zoom in and go through everything on detail. But it is a very detailed pathway that was developed across the province with input from both gynecologists as well as family physicians. So first of all, our patient profile and history. So we've touched on like who our postmenopausal patients are likely going to be. I'm not going to speak to primary ovarian insufficiency in today's talk because those patients are a bit of a different set. So a 40-year-old patient who has had greater or equal to 12 months of no bleeding followed by new onset of vaginal bleeding. So what we really want to know is has it happened once or is it happening recurrently? The volume, any precipitating factors, specifically like intercourse, trauma, other things inside the vagina, and if they have any associated symptoms. Um, Now, I wouldn't be doing my justice as a generalist who's also an obstetrician. Please rule out pregnancy. Our hospital policy before going to the OR is that everybody younger than 65 gets a pregnancy test. And although your patients may look at you sideways, it's always good to rule out pregnancy before we go down these pathways. We certainly don't want to get a placental sample when doing an endometrial biopsy. Risk factors that we're concerned about. So again, over 40, nulliparity, or if they've never had any babies, PCOS, irregular cycles, and I will asterisk that one, irregular cycles in the context of knowing that perimenopause will have irregular cycles. A history of Lynch syndrome, obesity, diabetes, the tamoxifen like we touched on, and unopposed estrogen. Big note, if it has not been at least 365 days since she has had vaginal bleeding, it is not postmenopausal bleeding. Another critical thing when referring to gynecology is a surgical history. We really want to know if she has a uterus and a cervix because we're basically looking for where the bleeding could be coming from. When we're going into assessment, I'm hoping that I'm saying this in vain to the group that is attending today, but please, please, please examine the patient. All of my partners and colleagues have had horrible cases where patients were not examined, and on their first presentation to our offices, we diagnosed a stage 4 cervical cancer or other cancers as well. This is an avoidable situation, and certainly if it's noted on initial pelvic exam, then they can be more appropriately referred to either colposcopy or gyne-oncology instead of waiting first to see a gynecologist who is then ultimately going to then put the referral through to colpo or gyne-onc. And so please look at the vulva and vagina. Please look at the cervix. Please do a bimanual. The red flags, similar to any other patient red flags. So if they look unwell, they're tachycardic, hypotensive, soaking through one pad an hour. Now, this can sometimes be difficult to elicit from patients because patients will often change a pad before it's soaked through because it's uncomfortable. But that like true kind of soaking a pad, soaking a tampon, and like needing to change it in less than an hour is bleeding that we want to see in the emergency room, or if they're febrile. A note on those red flags. Please send them to emergency department at a hospital with gynecology. In Edmonton, this is not the University of Alberta Hospital. Certainly, we all cover call for the University of Alberta Hospital, but that's telephone advice. And then ultimately, if the patient needs to be seen, they need to be transferred to whatever site we're at. And so there is a delay in care. And I've already touched on this. If you're worried about an obvious malignancy, go straight to the oncologist. Please skip me. In terms of investigations, if they're due for a pap test, complete it and then manage those results as needed. Screen for STIs in all patient populations. We've touched on the pregnancy test. CBC and ferritin can be helpful, especially if it's recurrent heavy bleeding, and a transvaginal ultrasound. And so it's always good to also inform the patient that the ultrasound that you're ordering will include a probe inside the vagina because some patients aren't expecting this and then will decline that portion of the exam if they're unaware of the importance of it. And so, and just from like anatomical landmarks, the features that we're looking for, oftentimes we will get much better pictures with a transvaginal probe to help us further kind of risk stratify the patient, as well as patients who have a lot of abdominal adiposity or obesity. The abdominal images just aren't the quality that we would like to properly risk stratify. Okay, management. Now, this is where many of the gynecologists will have differing opinions on. And I think that this workflow was actually developed through the asymptomatic endometrial thickening diagram. And so take this with a grain of salt when it comes to the endometrial thickness less than 5 millimeters and over 5 millimeters. Certainly less than 5 millimeters is reassuring, but if the patient has other concerning symptoms, if it's a high volume bleed, and certainly if it's recurrent, we need to see these patients and biopsy, if not hysteroscopy them. Most cancers will be thicker than 5 millimeters, but not all. If it's greater than 5 millimeters and they're bleeding, we definitely need an endometrial biopsy. You don't need to stop HRT prior to the biopsy, especially if they're taking their progestogen as prescribed. And then, of course, then we get the results. A lot of the time, we're going to get an inadequate sample. Now, part of the difficulty, and I think one of the biggest barriers, is that endometrial biopsies are tactile. And so when I do an endometrial biopsy and I am confident that I'm in the cavity from it's literally just the tactile feeling of knowing what the inside of a uterus feels like, and I get an inadequate sample, I'm reassured by that. But certainly if you're not sure if you're in the cavity, if you get a small sample, we're always happy to see these patients. The proliferative endometrium or hyperplasia without atypia, we treat with progestogens, the levonorgestrel IUD or progesterone are both options. When considering IUDs, I'm going to use some brand names. So Mirena has been studied for this, Kyleena has not. And so Mirena we will use to treat hyperplasia when we're wanting to try to preserve fertility. Or if they're a poor surgical candidate. Kyleena has not been studied out, and so prescribing a Kyleena might not give us enough progesterone, but those studies are ongoing. But ultimately, if in postmenopausal women we don't need to preserve fertility anymore, ideally we would be going towards doing a hysterectomy for them as definitive management. But again, there's many reasons why people would not want surgery, and so then the progestogens are a good option. If your sample comes back as hyperplasia with atypia or a carcinoma, then those patients go straight to gyne-oncology. You get to skip gyne altogether, and gyne-onc will see those. Okay, so I spend a lot of my time prescribing menopausal hormone therapy, so I wanted to specifically touch on the postmenopausal bleeding patients on MHT. Dr. Silgrant may have touched on this last week. And so one important factor is to determine if the patient is on continuous combined MHT, so getting some source of progesterone daily, or if they're on cyclic. If the patient is on cyclic MHT, we're expecting bleeding because essentially cyclic MHT mimics a quote unquote normal menstrual cycle where half of the month they are on progesterone and the other half they're off. And so when they're off progesterone, we can have a progestogen withdrawal bleed. We do tolerate some bleeding in patients that have recently had a change to their MHT, and so we can tolerate it up to 6 months since that change. But we really don't like it if it's heavy or prolonged. And so this is part of that like art of medicine. If they have a small amount of spotting, even a few months in a row after like I've increased their patch or their oral estrogen, I can tolerate that. If all of a sudden they're having heavy prolonged bleeding, especially if it's the kind of bleeding that makes them come to the emergency room, I'm not going to tolerate that, and it needs to be investigated more urgently. The other thing is to ensure that the patient is taking their progesterone appropriately. What I say to my patients when I'm starting them on MHT is that the estrogen is going to fix a lot of the symptoms that you're having, especially those vasomotor symptoms. The progesterone is going to give you the side effects. To explain those side effects to my patients, I will often say, think about that time when you were younger, right before your period. You get the mood changes, you get the tender breasts, you get the bloating. All of that is from the progesterone. And so sometimes the patients don't want to take the progesterone, at which point they're on a post-estrogen state. And then we need to either find a better option for them for MHT or kind of reevaluate whether or not it is safe for them to be on MHT. We don't need to stop hormone therapy while investigating the postmenopausal bleeding patient for those who do need further investigations because they will have a massive relapse of their symptoms. And if the risk of them having a new hyperplasia or endometrial carcinoma, if they have been taking their progestogen appropriately, is very low. Okay, asymptomatic thickened endometrium. So it is technically defined as an endometrial thickness greater than 5. And so, like I mentioned, I think this is where they got the 5 millimeters for the clinical pathway in a postmenopausal woman not experiencing vaginal bleeding. So this is the key difference. Asymptomatic, not bleeding. Our postmenopausal bleeding patients are a whole other ballgame. In patients with a lining less than 11 millimeters, the overall incidence of endometrial cancer is incredibly low, and so it's reassuring for us. 90% of women with endometrial cancer will have vaginal bleeding, and so we are less worried about these asymptomatic thickened endometriums than those who are having postmenopausal bleeding. And then just some caveats. There are no indications for screening ultrasounds for any gynae cancers, so not uterine, not ovarian. And women on tamoxifen should not have screening ultrasounds because then we're kind of opening up this can of worms where where we need to kind of rule out malignancy, but we're introducing risk to the patient when overall it's not as risky as we might be worried about. Who are we worried about? Older patients, if they've never had any children, obesity, hypertension, diabetes, tamoxifen, and if they have a history of Lynch syndrome. Concerning features that we see on ultrasound would be increased vascularity within the endometrium, heterogeneity, or a fluid collection within the uterine cavity. And so this is out of the SOGC guideline. It's about a year old now on asymptomatic thickened endometrium. And this is a good kind of guideline. As you can see, those postmenopausal bleeding patients, they're going straight for biopsy or hysteroscopy or a hysterosonogram if you think there's a polyp. But right now we're talking about the asymptomatic ones. So if it's less than 11 millimeters, it's a low risk patient, then we just can observe and reassure. If it's a higher risk patient concerning ultrasound features, then we consider biopsy. I feel that most of us would, obviously, with shared decision making with the patient, most of us would lean towards biopsying these patients. Either biopsying or doing a hysteroscopy, depending on patient preference as well as difficulty of the biopsy in the office. And so if the sample is inadequate, we're confident. We can, again, consider how worried we are about it and either provide reassurance or repeat in 4 months. But those high-risk people, we're going to take them for hysteroscopy. We're happy to see these patients. These are the ones that really need that like surgical intervention. Endometrial biopsies are also incredibly painful. Some patients do fantastic, and other patients, I will warn all of my patients that this is probably going to be the most uncomfortable biopsy that you have had before. My style tends to be say that it's going to be worse and then they're pleasantly surprised. But endometrial biopsies are very painful. And so I do also offer the patient to come back to another appointment if they're really not ready for that today. Because if it's not what they're expecting, it's not a fun surprise in a gynecology office first thing on a Monday. And so if the patient is going to be coming back to have the biopsy completed, then I will tell them to kind of pre-medicate with Tylenol, naproxen, whatever they would normally use for pain. Um, and then, of course, it comes into the question of freezing a cervix or like applying like local, whether or not we're using misoprostol to help open that cervix. That the misoprostol tends to be pretty individual to which gynecologist is doing the procedure. Personally, I don't find it all that helpful to complete the biopsy, and it can be quite severe cramping prior to the procedure. I try to reassure the patient that once the biopsy is completed, the pain pretty much resolves, might have some mild cramping afterwards, and that the biopsy itself takes about 10 seconds. Sometimes we need to do it twice. And so, as long as we don't have a lot of cervical stenosis, then most patients tolerate it okay. I'm not their best friend after the procedure, but they do okay. And so I just wanted to put these links up, and I'm sure it will be shared with everyone afterwards. So there's the postmenopausal bleeding pathway that we've kind of gone through in detail today, as well as the gynecology referral pathway, and I'm just going to bring that up now. And so this version of it was published this month. So this is hot off the presses. And I think one thing that can be frustrating as a generalist, the way that we do our call is different at every site, but we do receive a lot of rapid calls for things that shouldn't be rapid calls. And that can be frustrating because it's often pulling us away from labor delivery or more emergent referrals through the emergency department. And so if you think your patient needs to be seen immediately, that's really when we're using rapid or going to the emergency department. Like I said, make sure it's an emergency department that has gynae in-house. We've gone through some of the clinical pathways for referrals. Non-urgent advice, ConnectMD is great. A few of my colleagues are on it, as well as submitting referrals. Now, I know referring to gynecology and obstetrics is difficult since all of us are in private office. There is no centralized system. We tried to do it, and then my understanding is that it didn't really work because not everybody was on board. And so hopefully in the future, we'll be able to be more similar to general surgery, GI scopes kind of idea. Um, But please send in referrals if our offices are unable to accommodate the request. I know my office will often make suggestions as to other people available in the city. The other thing to consider as well, if an endometrial biopsy is not a skill set that you have, there are many family physician clinics that specialize in women's healthcare within Edmonton, and they are more than happy to see these patients. And that way, the patient will probably be seen more quickly than necessarily waiting in the gynae office. I was mentioning before that my whole gynecology practice could probably be postmenopausal bleeding. And so, unfortunately, we just don't have the capacity to see all these patients. So, please use your colleagues who have these skill sets, and then they will call us if they need us. Here are my references. And then I left lots of time for questions. I hope we can have a good discussion.
Fantastic. Awesome. Yeah, we have a bunch of them. So let's start out with Julia. She's commenting, when doing cervical cancer screening in someone who's having bleeding, is HPV primary testing appropriate or do they need cytology as well? So right now, if over 50, the default is the HPV primary screening with reflex cytology if positive for high risk HPV.
Yeah, my bias is going to come out a little bit. The rollout for this was interesting in that I learned about the rollout from the family docs. They didn't actually tell any of the gynecologists that this was going to happen. And so I think that's where kind of putting on your requisition, what you're seeing, what you're worried about can be very helpful. Like certainly if there's a lesion or a mass, still complete the PAP, but put that in your clinical history. The pathologist look at it, and that will also flag it that it's going to one of our gynae pathologists. Because I did have a patient recently that I got a referral for in that the family doc saw a concerning cervical lesion. The PAP was pending. I recommended referral straight to colposcopy, but I kept an eye out for the PAP results, and they just did the HPV primary screening, which is really not what we need at that point. It came back negative, but there was a mass, and so regardless, that patient should go to colposcopy.
Okay, awesome. Sreyat is asking, how does endometrial hypertrophy develop in postmenopausal women when they lack the estrogen to stimulate the endometrial growth?
Um, I wish I knew. And so it really it depends on the exact patient, right? And so this is where those like high risk patient factors come in that like your obese patient, diabetic, hypertensive, especially in the obese patient, we know that adipose tissue has some estrogen release. The other interesting thing that is not yet published on, but I'm expecting that someone who does more research than I is probably looking into it. We've been getting a lot of new postmenopausal bleeding on patients on the GLP-1s. And like I said, I hope someone is looking into this. But it came up at the menopause conference the last 2 years in a row that we're seeing this in our patients who have been rock solid stable on their MHT. We have not touched it in years. They started GLP-1 and now we have new bleeding. When we're looking at those patients in the context of them being on estrogen replacement, the current working theory is that since most of us will use an oral progesterone, that there's a change in the progesterone absorption, but we're also seeing this in patients who aren't on MHT. And so we think it's something to do with the adipose and mobilizing those estrogens. But again, I'm sure some smart person is looking at this in more detail.
So interesting. And Sreyat is asking all kinds of questions. So we're going to stick with Sreyat for a sec. The first one is women on continuous combined MHT don't usually experience any bleeding? Question mark. So I guess that's your point. As long as they haven't suddenly lost their Marina.
Yeah. So IUD still where we expect it to be, and patient taking their progesterone. Like I said, sometime, not often, but sometimes if I'm increasing a patch or whatever we're using for estrogen, we might have a little bit of spotting. But we're not necessarily expecting bleeding on patients who haven't had any adjustments to their MHT. But certainly, like these patients can still have the other reasons of bleeding. So, still examine the patient. You can talk with them about whether or not a biopsy might be correct for them. Cancers are going to continuously bleed. If they're continuously bleeding, the risk assessment then goes towards biopsying these patients. You don't have to stop the MHT. Make sure they're on their progesterone and they're taking it appropriately, and that nothing weird or wonderful has happened. I have a patient who is very near and dear to my heart now. We met each other about 8 months ago. She had recurrence of vaginal vault endometriosis 35 years after her hysterectomy because she was on vaginal estrogen, which is incredibly rare. And I thought for sure I was going to diagnose a cancer, but the pathology came back as endometriosis. And so we see all kinds of weird and wonderful things in gynae.
No, that's actually was a clarification, Danica, on that. That was a question I had on the
Yeah.
slide. For these patients, if their progesterone is an IUD, then presumably you have to remove the IUD to do the biopsy.
No,
You
you leave
don't?
it. Yeah, you can feel it. It feels weird.
Okay.
I
Okay.
know, I know, I know, I know. But so we like in our hyperplasia without atypia patients that are preserving fertility, we like to pop IUDs in them to treat the hyperplasia, and then we're still doing the biopsy every 3 to 6 months. And sometimes IUDs fall out, but the chance of it falling out is very low. The pipelles are smaller than the IUDs themselves. So you just pretend it's not there and you can still do the biopsy.
Okay. All right. Last one here for Soraya, and then we'll pivot to some other folks. But just wondering about endometrial atrophy treatment causing the postmenopausal bleeding. How's that treated?
Um, what do you mean by endometrial atrophy treatment?
I think it's because that first slide where you gave the differential diagnosis of the different etiologies of the reasons why people bleed.
Oh, yeah,
And
let me
one of
flip
them
up.
that you highlighted was atrophy. I think correct me, sorry, if I've got that wrong, but right there,
No, it's
hypo,
completely correct. And so it can be hypertrophy or atrophy, both of the endometrial lining or of the vulva vagina. And so I'm not gonna I specifically avoided genital urinary syndrome menopause because I know it's coming up. But what basically the tissue gets thinner, both the vulva vagina and within the uterus. It gets thin and then it bleeds more easily. So think about this, especially in your patients who have new postcoital bleeding. We see the same thing in the uterus. A lot of the time, the patients that I have to take to the OR for hysteroscopy, I'll pop the camera in and it will look completely atrophic. Do I have a good reason as to why it bled? No, but we rule out those malignant causes.
and then how do you treat it?
Ignore it.
Okay. Would vaginal, like Vagifem or something help?
Vagifem will help like vagina vulva, but intrauterine, it's a reassuring finding. You don't treat it intrauterine. Like it's not an indication for HRT or anything like that. Certainly like treat the vagina and the vulva, but you don't need to treat the uterus.
Okay, all right. So now we're going to pivot to Hai, who's giving a case of a 55-year-old female with a history of PCOS, menopause, on Eliquis for an unprovoked PE a few years back, who's calling for bleeding, so changing pads every hour, ongoing for a week. Should they discontinue the Eliquis while waiting to be assessed?
Depends on how heavy the bleeding is. And so if we're if they're in that category of changing a pad every hour, they're coming to the emergency room for us to see. These are our most difficult ones to manage, like especially those who we can't take off of anticoagulation. What we would normally do is probably pop in an IUD to help temporize that. We could also consider like an endometrial ablation. When I do ablations, I do not do ablations in women younger than 40. A lot of my practice in the menopause clinic is me taking patients who have had an endometrial ablation when they were 30 to the OR because now they're having postmenopausal bleeding, but really it's because that ablation is expiring. They last 5 to 10 years, so I don't do it in patients younger than 40. And I tend to always pop an IUD in at the same time, both for contraceptive benefit as well as kind of also managing bleeding. So it's kind of a double hit of we're going to manage this surgically and medically at the same time. Sometimes we will shut these patients down with medications such as Lupron, but oftentimes after a dose of Lupron, we'll get increased bleeding. So it's a bit of a balance. There are many conversations between hematology and gynecology and negotiating, keeping the blood in the body and minimizing clot risk.
Okay, awesome. To the verge is the answer to that. Okay, so
Yeah, soaking pads every hour. Come on down. We're happy to see.
awesome. Okay. Leslie's asking about when do you proceed to hysteroscopy, DNC versus endometrial biopsy?
Patient preference, or if I can't get in through the cervix. Some patients, especially if they've had an endometrial biopsy before, they really don't want to have another one. And so I like I'm very much a component of informed consent, and so then that I will take them straight to the OR. The other instance is if someone who I know is comfortable with an endometrial biopsy has attempted in their office and they couldn't get in. I'm just going to take them for hysteroscopy. Unfortunately, on my site, we don't have a hysteroscopy suite. It was trying to be developed a few years ago, but I'm at a Covenant site. There's already a Covenant site with a hysteroscopy suite, so it wasn't felt that we needed them in both locations. And so the Misericordia has a hysteroscopy suite. They have a sorry, I should have linked their kind of referral pathway for that. But essentially it's physician led, so there's not an anesthetist, there's a nurse and a gynecologist, and so it's sedation for these. But they do have pretty rigid criteria for the patients just because there isn't an anesthetist there. But that is sometimes a good option to get to hysteroscopy faster. I think we could have a hysteroscopy suite running 24/7 in the city and not catch up on all of them.
Oh gosh, okay. Actually, that's a related question, and it's flown out of my head, but the new procedural sedation that people are using in the office for this.
Oh, Penthrox.
What's it called again?
Penthrox is the brand name.
Xbox. Yeah, can you comment on that? Do you use that with this?
So I haven't used it because one of my partners on my office asked either the CMPA or CPSA if we could use it in our office and if there was any stipulations to it. And they said, absolutely not. You cannot use it in your office. We will not cover you because there is an incredibly small but still there risk of malignant hypothermia. And if you don't have the facilities to treat that, then you can't use it. And so now we're kind of like, okay, well, now we asked for permission and they said no. So we're not using it in our office. Like some people at the menopause clinic will use it. I just haven't had it because now, of course, we can't.
Okay.
People love it who use it.
Yeah. Okay. No, well, that's useful. That's useful. Like a little bit of a thing for people to look into if they're
Yeah.
about it. Leslie has a follow-on question here about whether, so if you have someone who's on a GLP-1,
Yeah.
would there be value in doing a progesterone level in them? Now there's acronyms here. So,
Yeah.
okay, helpful in PMB. I'm assuming that's
Just
postmenopausal.
menopausal bleeding. Yeah.
And GLP-1 RAs. I'm not sure what the RAs are, but anyway, any role
Um,
of hormone levels in these folks?
yeah. So in my I very rarely send off hormone levels. And this is one thing that is difficult at the menopause clinic because if they've been in private clinics, they're used to having their hormone levels checked. Because essentially we don't have a target dose for progesterone. Like we don't have a serum level that we know is going to be endometrial protectant. Certainly if it's zero, that's a problem, but it's not like I'm like, "Oh, I need to get you to a progesterone level of X so that I know that I have like protection." I will sometimes do estrogen levels in my patients who are doing well and then all of a sudden have new symptoms, especially if they're on a transdermal. And those will be the patients that I'll be like, okay, I'm willing to accept the increased risk of oral because you're not absorbing it transdermally as expected. But those reference ranges that come back on the labs are all for cycling women. This has not been studied out. And the number of times that I say that in a given day at the menopause clinic is more than I care to mention, because we don't have that serum level that we know is going to be protective.
Okay, awesome. Yeah, Julia's provided some helpful comments in the Q&A around commenting that she's spoken with CPSA about Penthrox. And
Perfect.
it's like more appropriate measured guidance for its use in an outpatient setting will be coming sometime this year, which
Amazing.
which would be really helpful, given how painful these things are. Oh gosh. It is used in the pre-hospital setting all the time, and in Australia, sports coaches use it. But commenting that the current guidance is different. So it sounds like this is an excellent area for us to push for some more clarity and some more, awareness of what to look for, etc. Um,
Yeah. Yeah, because the few practitioners that I know who are using it, love it. Like it works really well. But yeah.
Okay, well, that's coming. That's helpful. So, Bao's just wondering about a link to the presentation. Bao, just to share, what we do is rather there will be a video shared with everybody, and then we do have the pearls for practice, which is a summary of all the materials that's for quick reference, so that we can not have to watch the whole presentation to remember something when it comes up 3 weeks from now, and we're like, oh man, we forgot. That's so. Thanks to Andrea and to Natasha in the background who make those. Okay, Jan has a question. If a biopsy comes back as atrophic and a 2-year post MP bleeding patient is on 50 micrograms of estradiol and 200 milligrams of progesterone on that dose for sleep, and we don't want to change this, would you recommend that we increase to the 75 microgram patch? That's the first part of the question.
So no, you titrate your estrogen dose to vasomotor symptoms. So you don't titrate it to the biopsy results. It's a reassuring biopsy result. I wouldn't make any changes to their MHT.
Okay. And then the follow-on part of this is what if she was only taking 100 milligrams of progesterone and the biopsy comes back as atrophic? Would
Same.
it, okay, all
Yeah.
right.
Everybody loves their progesterone. People either love the progesterone for the sleep, or they hate it for the side effects. And then I've got my patients now who I've done hysterectomies on for a variety of reasons, and they're like, "But I don't want to give up my progesterone." And so it's always a conversation, right? My preference is for them to not be on it because I don't love using a hormone for the side effect of sleepiness. But like I said, patients love it, and so there are other hills that I die on. Because and we all know that the Women's Health Initiative, there were problems with that study. But one of the areas when we were looking at breast cancer risks, so in the estrogen only group, so those who had had previous hysterectomies, they didn't see any change in breast cancer risk. But it was the estrogen and progesterone that they saw that increase. And so it's not enough for me to be like, absolutely not, I'm never prescribing you progesterone again. But it's a lot of what we do at menopause is shared decision making. And with the risk benefit ratio for one person, it's not going to be the same for the next. But yeah, I totally get the progesterone for sleep. If they like it for sleep, they're not giving it up.
So Jan has a follow-on just because I think
Yeah.
what she's trying to figure out is in attempting to stop the bleeding that she's having,
Oh, okay. Yeah. Yeah.
would,
So
would, would the estradiol increase help to fix it?
yeah. That probably not. And so, yeah, some people, their uteruses just like to bleed on MHT. When I was with Wendy Wolfman in Toronto, she really liked, and again, I'm going to use a brand name here, Duaviv, which is the estrogen and the SERM. Um, because and for whatever reason, using a SERM instead of progestogen in this patient population, like the recurrent bleeding on MHT, it seems to work a little bit better. It's difficult because it's a once a day like PO medication. And so you can't titrate your dose of estrogen. Rough equivalent is a 50 patch is like one Duaviv tablet. And so if they're on a 50 or less and keep having this bleeding, Duaviv might be a good option. They do have a lot of packaging issues, so it comes on and off the market, which has been a bit of a headache. But the SERM seems to stabilize things better than the progestogen.
Okay, awesome. So Jan, just pop in the Q&A if there's more bits to that to make sure we've done justice to your.
Absolutely.
Please do. Okay. Karen's asking regarding continuous combined MHT, if the
Yep.
estrogen dose is the 75 to 100 microgram patch, is daily 100 milligram micronized progesterone considered adequate?
Not really. Um, and so like 75 is one of the gray zones where some docs will put them on the 200 and some will still stick to the 100. 100 microgram patch definitely needs 200 daily. Um, or an IUD.
Okay. And
Uh,
if they have the IUD, can you just be free and
you can
happy?
do whatever you want because you're giving them way less estrogen than what they were producing before.
Okay. And so the progesterone's covered and you can just carry on. Okay.
Yeah, and also remember because we use it for the hyperplasias, right? So we can do whatever we want with that estrogen dose.
Okay.
My
And then,
POIs go up real high.
so I beg your pardon, the what?
Oh, the premature menopause or the primary ovarian insufficiencies, because I need them at a minimum of a 100 patch, but sometimes they need a little bit more as well. And if they've got an IUD in, then we're just good to go.
Okay. So Ananina is asking, what's your experience with all monthly versus cyclical progesterone and experiencing stomach symptoms such as bloating?
Yeah, so yeah, that's the progesterone will give you all the side effects, estrogen will give you all the benefits. If when people are really sensitive to the progesterone side effects, there's pros and cons to cyclic. So they'll have half the month where they're not on any progesterone, but then half of the month that they're on the progesterone, it is a higher dose, so they will have worse symptoms during that time. And then whether or not they care about bleeding during the off time. Again, IUD in this patient would be fantastic because the like that a lot of the side effects from progesterone are minimal, if any, with an IUD. The other thing to consider that so some of my patients have decided that they are going to use their progesterone vaginally instead of orally. This is completely off-label. This has not been studied. Patients find it online and then they start doing it. And again, I'm a harm reduction menopause care provider. They anecdotally say that it improves their symptoms. It's not my preference. My preference would be for an IUD if they really can't tolerate oral progesterone.
Okay. And then Dennis is asking, how worried are you when you do a pap smear and the cervix looks friable with no visible lesion? And would you repeat the pap if the patient's up to date, but you did the speculum exam and noticed it and the patient's asymptomatic?
Yeah, and so there's two main reasons we can see like the friability. Common things being common in someone who has had always normal PAPs would be more of the like genitourinary syndrome of menopause pathway. So if you're ever worried about a cervix, do a PAP and write your findings on the requisition. Um, And then this is a patient that you can consider starting them on a vaginal estrogen, because similar to the vagina, like having micro tears and bleeding, excuse me, the cervix can as well.
Oh, that's interesting. So how do you sort that out, Danica, between just like a really prominent ectropion, like some younger women might have? Would you put
Um,
vaginal?
well, I think it's pretty nuanced in that you don't really see a prominent ectropion in your postmenopausal patient. And so like it if postmenopausal cervixes should be pretty boring. Like they're pretty
Okay.
small, they're pretty pale, not a whole lot happening. The friability can definitely be from just the speculum itself if GSM, the genital urinary syndrome of menopause, is a concern. And so if it's a wonking looking cervix at all, PAP, colpo referral.
Okay. Wonky. Yep. If it's wonky, Dennis, refer. Actually, sort of really one question I just ask is around adenomyosis. So
Yeah.
where does that fall in that whole list of differentials that you provided at the beginning? And sometimes they bleed. So what do we do about that, if anything?
We see like the adeno seems to be more of a component in like our abnormal uterine bleedings in our premenopause, especially our perimenopause. So adeno, we get endometrial cells inside the myometrium. They continue to bleed every month, and then the uterus gets bulky. When the uterus gets bulky, there's more surface area for endometrium. So then there's more endometrium to bleed every month. They also get the wicked bad cramps because the endometrial cells within the myometrium are bleeding. It has nowhere to go, it's trapped. So then the muscles get twitchy and crampy. And so I find that adeno is a bigger thing for my peris or like premenopausals. The bulkiness of the uterus that we see in adeno often goes away in like especially if it's been many years since menopause because you don't have that constant bleeding of the endometrium. So eventually that blood gets reabsorbed and that uterus shrinks right down. If we see this like heterogeneity in a like very postmenopausal patient, then we are getting more concerned for like a cancer or something invading the myometrium because we don't really see adeno, especially when we're far out from menopause.
Okay. And then Bow's asking, in patients with bleeding, about a month after starting HRT with patch, should we continue and monitor? What if it continues more than 6 months after starting the HRT?
Yeah, and so if it's a small amount of bleeding, and by small amount, like I'm a gynecologist, so I realize that my tolerance for blood is different than a lot of people. And so if it's a small amount of bleeding, like a light period or spotting, continue to monitor. If it's all of a sudden super heavy, super worrisome, that needs a biopsy. But again, we can tolerate a small amount of bleeding as we're making those, like as we're titrating up on HRT. And if
Awesome.
they have an IUD in, I don't care about bleeding.
And I'm like, and you're gonna do the biopsy with I just see Danica. If I try that the first time and I take out the IUD, I'm gonna call you and be like, Danica, the IUD felt
Oh,
like
don't worry. You can call me and be like, I tried. It did not go as you told me it would.
this did not work out. Okay, awesome. But yes, we'll be bold. We will try. We will try to reduce referrals. Awesome. We'll say thank you so much. I can't believe this. I'm glad you left so much time for questions. There were many, and they were great questions. Thanks everybody for coming. I think people got clinic here in a couple minutes, so probably need to wind up. But we know this was so much extra work for you, and we're super grateful to you for helping everybody get smarter. And just a little shout out to the procedures. We had that endometrial biopsy course that was super well attended, and I think we've got like 18 people on the wait list to do another one. So hopefully, all together, we can try to just get all of us, a little bit more savvy in the space and cut down on referrals and yeah, and just get these patients seen. So thank you, everybody. So fantastic. Oh, and everybody's saying, thank you, invaluable, huge thanks. I hope you're looking at, you should be looking at the sidebar on the Q&A, Danica.
Oh, perfect. I'll open it now.
Everybody's chiming in and saying how much they appreciated you and you taking your extra, taking your own time for this and, creating value for the community. We really value it. Thank you so much.
Yeah, of course. Like we all want to do what's best for our patients, right? And we know that we are working in a system that is not optimally functioning. And so we never want patients to sit on our wait list and then we diagnose a cancer. That's not good for anyone. And so happy to help and empower as many people. What I tell my med students all the time is don't be scared of the vagina. It doesn't bite.
Yeah, no, and you know what? And such a great thing. We do have so many colleagues in our community in primary care who just have real interest in this space too. So also really great to figure out like maybe we can build capacity in all, in our PCNs and the clinics and you know,
Yeah,
just really try to as a community, get these patients seen and then make sure the ones that really need you end up with you. So awesome.
yeah.
All right. Thanks everybody for coming. Fabulous. It's 1 o'clock and thank you, Nick, and in the background for all the coordination for this. And Natasha, Andrea for all the work you're doing. And we'll get these pearls out and we'll look forward to the next event. So thank you so much.
Thanks.